Yeah. He's general surgeon.
So I think we'll get started here. Thank you all for coming to the Center for Applied Community Research Colloquium. This is scheduled for about an hour or so. Is that what you guys plan? I'm going to, Tien Ung is going to lead this discussion for today, and we'll introduce her colleagues, but it's on ensuring program and implementation fidelity in community-based research with immigrant and refugee partners, lessons from 2 case studies. I'm glad all of you could come today, and let's get started. We are taping this, so we'll make this available to all of you who couldn't come today.
Thank you, David. I appreciate that. Before I get started, I do want to take just a couple of minutes and introduce my community partners. Here with me today are Dr. Joel Piton, who is a trained medical physician from Haiti and also a mental health counselor here in the United States, and is affiliated with Boston Medical Center, as well as CACR, which is a social service organization that provides an array of services to the Haitian diaspora here in Boston, Massachusetts. They're located in Dorchester. And also with me here today is Dipanwita Bhattacharyya, and Dipa is the Director of Communication, Outreach, and Education at ATAS, which is the Asian Task Force Against Domestic Violence, also located in Boston, and is the only multilingual social service organization, nonprofit organization that provides both case management as well as prevention services and shelter services for Asian women and children who are affected by intimate partner violence. So I'm really thrilled to have them here with me today. Just to give you a sense of where we'll be going in our talk today, we engaged in 2 different research projects, and we won't be talking about our specific findings for those studies today. Rather, we will spend this time talking about the lessons that we learned drawing on community-based participatory research methods to inform the current debate around and the tension regarding program and implementation fidelity and evidence-based practice. And so we feel like we learned a lot from each other, engaged in these projects, which ran the gamut, each of them, for about 3 years, and had, I think, a really unique opportunity to zero in on several process variables that we think would really inform that area of study. So in that regard, I just want to start off by saying that generally the tension that I'm talking about with regards to translation and implementation science is trying to strike that delicate balance between cultural authenticity and relevance and adherence to the actual parameters of any type of intervention or prevention model. When this tension or balance moves into communities where the participants and the constituents are of different racial and ethnic backgrounds and different cultures, it becomes quite messy, which is captured, I think, quite well in this slide. I really felt like many of the challenges that we faced were really about scientists and researchers coming to the community, finding different ways to say, hey, hello, and asking questions which we thought were pretty obvious questions that we needed to understand in order to create and generate sound models of practice that were grounded in evidence. And when we sat at the table with our community partners, they very quickly taught us that there was a lot more for us to learn. So in sum, the 3 lessons that we're going to talk about from our 2 case studies are that effective evidence-based initiatives in immigrant and refugee communities must be driven by local level needs and perspectives. And so we'll spend a lot of time talking about what it means to have local level decision makers driving that process and try to operationalize that for you to understand. The second is that the actual research philosophy or paradigm that we believe lends itself best to effective evidence-based research is community-based participatory research. And so we'll drill down on some of the lessons that we learned and the types of adaptations that we had to make in engaging and designing our research from a community-based participatory methods, research stance. We learned that participatory can either be with no P, a little p, or a complete and big and total P, and we're advocating for the latter. And then thirdly, the thing that we learned is that we really have to make a commitment to shift our paradigm in terms of the underlying theories that drive science and that drives research design. So we're advocating for a shift from a positivist approach and stance to one that is informed by complexity science. So first of all, why is local level accountability important? Well, apropos to this cartoon, if we don't have local level understanding, then we run the risk of encountering the usual problems in implementation science that prevents scalability, which is user buy-in, fidelity to the actual treatment model, and organizational restructuring to support implementation of the treatment model. So when we talk about local level accountability, we decided that these 4 pieces of principles really helped us to ensure that our work and our design and our collaboration was true to the spirit of CBPR. The first is that when we engage in research products and studies, we want to begin from a position of what we have coined transposed translation rather than back translation. Back translation, as many of you know, is the process of taking a study and an instrument, a protocol that's developed and usually normed on a community and a population outside of the target community that's of interest or has become of interest, translating that protocol or that instrument into the target language, and then having another person of that community translate the translated instrument back into English. The idea being that you want to retain the philosophy and the principles of the program or the instrument. We're advocating for translation to be transposed. In mathematics, when you think about transposing variables, the idea is that you switch the positions of variables within an equation in order to maintain balance and equality. And so from this perspective, we believe that effective implementation science in immigrant and refugee communities has to start with the communities themselves, discovering and understanding from the community partners what variables and what processes and relationships are significant and of interest to them. Model building would then come out of that process in an iterative way, and then those models and that evidence is then translated back to the research community for scalability and for testing with regards to rigor of the model that was developed. The other principle that was a key central part of our work together was that we focused our partnership on model building, which derives from the idea of transposed translation, rather than on implementation. So we began our partnerships with the explicit understanding that folks in Dr. Piton's community and the youth in Deepa's community, as well as her staff and Dr. Piton's staff, already had a good, strong grasp of what the local level needs were and already had a good sense of where to intervene, how to intervene, what was helpful, and what was effective. And so our work was really about sitting with them absorbing their processes on a daily basis, joining their communities to learn from them exactly what those mechanisms were, what target variables were of most importance, and what would be meaningful to the community to ensure community buy-in. Out of that work came the development of a model for prevention and a model for program design in terms of help seeking relative to mental health of Haitians in Massachusetts. We contrast that with much of the implementation science, which is driven by scientists and researchers and academics drawing from evidence-based protocols that were developed and normed on communities outside of our target communities and then adapted in various ways in order to get constituent buy-in. The third thing that we learned in coming together is that a very important driving, again, principle or force of research design in immigrant and refugee communities is the focus on impact, again, versus adoption and adaptation. So we really felt like as we worked together, the questions that we kept asking ourselves and challenging ourselves with is, how do we know that what we're doing here is relevant to the community? What impact does this have on the community? What return will this give back to the community? How will the community and the constituents receive the information that we have, as opposed to taking Western standards and protocols and models and translating them back or adapting them for the community to digest. And all of this sort of converges in a place that really drives the overall philosophy of our approach, which was really about underscoring that our work at its core is about the process of knowledge exchange and transfer, again, versus knowledge translation. That this process of generating and exchanging knowledge and transferring and molding and shaping that knowledge for dissemination was much more effective, authentic, and culturally relevant than simply just translating knowledge from one group or from one culture to another. These principles to us were important because we learned that without community engagement, knowledge transfer could not happen. I sat with Dr. Piton and Deepa for 3 years and listened to several stories that they shared about partnering with other academics or scientists and engaging in very exciting and interesting work. Yet at the end of the day, whether or not it had strong impact or sustainability in the community was up for grabs, and whether or not they learned anything from that work or their capacity was built in any way was also up for grabs, which is what I really liked about this cartoon here. So just a quick overview of community-based participatory research. As many of you know, the principles that we focused in on in our work together are these 5, which in many ways parallels many of the what we call the cultural and social standards of ethnic communities. So when we think about community-based participatory research, we think about it with a big P and come from the idea that community itself is not a standalone variable, but rather it's a unit of identity and therefore a unit of analysis. It's also a source of capital rather than a domain of study. We worked from the perspective that partners are equal and collaborative throughout the entire research project, from the point of conceptualization through to design, through to data collection, through to data analysis and dissemination. And in each of the 2 cases today, you'll hear how we thought about making sure that the partners were equal and collaborative players at each part of that process. The project that Dr. Piton and I worked on really was organic in many ways. Our meeting was serendipitous, and he had already began a study that he invited me to join, which made the conceptualization together and collaboratively from the very beginning quite easy. And in the case of Deepa's work at ATASC, they had been invited by the Robert Wood Johnson Foundation and had been selected out of 46 organizations, and were a final 8 to engage in a prevention study, a prevention evaluation project that was quite unique in that it was geared, the purpose and the idea of the funds was geared towards building evaluation capacity at the local level. So from the start, I think the foundation really felt very strongly that community-based participatory research was the way to go. And we discovered along the way as we were working with them and their research consultants that they came at it with somewhat of a little p, and we spent a lot of our time pushing back with a larger p, and wanted to share some of those insights with you as well. Again, knowledge integration and action for mutual benefit were driving principles in all of our decision making whenever we came to points where we needed to make specific decisions about informed consent, data collection, where we would collect the data, how we would collect the data, who the data belonged to. All of those discussions were had right from the get-go together in full transparency and with full discussion with regards to who it would impact, why, and how much. And it was those 3 areas of discussion that really drove many of our decision-making principles. And finally, the piece that I think made our work quite unique and transformative for both them and for me is that we worked quite closely in what we saw as a very cyclical and iterative process of co-learning. And so from the get-go, apart from deadlines and infrastructure that were imposed upon us by funding bodies, we worked really hard to make sure that our work was following the rhythms of each of the organization and each of the partners' needs. And I think that really allowed us to learn organically about what was happening in those communities, as opposed to sort of forcing them into positions of being research participants for the benefit of our learning. And so finally, in pulling these projects together, what we hope that you'll get from us today is the idea of this paradigm shift, as I said earlier, that effective community-based participatory research in immigrant and refugee communities really requires a fundamental shift in our philosophy and our approach to research, one that moves from the position of a strict positivist approach to one that embraces what we see as an emerging and very dynamic and exciting field of complexity science. Complexity science is something that's driven by the study of complex systems, which requires that the teams immerse themselves in the system, expecting and looking for nonlinear change rather than strict linear relationships. So to that end, the areas of focus and the variables of interest are all anchored around processes that are reflective of self-organization, self-adaptation, self-repair, or this very powerful and exciting concept called emergence, right? Allowing yourself to sort of be in the system with the folks who are there, taking close note of what emerges, and then looking for the patterns that are associated with that emergence as a way to, again, design, manage, build, and identify models of practice. So I wanted to give you a brief overview of the sort of paradigm or the framework that really guided our work together. And I'm going to ask Deepa to come up and tell you a lot more about what we did when we were working with ATASK, because it was their community. I get to do the boring part. Thank you.
Hi. Thank you for having us here. And I just wanted to start off by saying that I'm just coming off a bad cold, so if I start croaking, my apologies. I work at the Asian Task Force Against Domestic Violence. We are an organization that works with domestic or intimate partner violence victims, and all our clients, about 97% of our clients are from Asian immigrant communities in New England. So we are the only organization that has prevention and intervention services along with a shelter in New England for Asian victims. So it's a diverse, very, very diverse community. Even though we put them all under the Asian American umbrella, it's extremely, extremely different. So we have to take different approaches for different communities. What works for the South Asian community definitely does not work for our Vietnamese communities. So when we approach each community, we have to devise different approaches. The study that we're going to talk about today is the Robert Wood Johnson Foundation study that was called the Strengthening What Works, and it focused on organizations that were providing services, largely prevention services, in immigrant and refugee communities all over the country. But before that, I wanted to talk a little bit about why we did research, because we are a small organization and it's very difficult for us to find the resources to justify doing research. Leading up to 2009, most of our evaluation was really focused around gathering numbers for grant reports. So we were really reporting success in terms of number of clients served, number of outreach events conducted, but we were not evaluating the effectiveness of our services. And which I think this study really enabled us to do. The process was a long drawn process. It started with researchers in the country coming together, and they came up with a list of 46 organizations that were working with immigrant or refugee populations in this country around intimate partner violence. And from that list of 46, they sent out invitations and asked us to come up with proposals around prevention, evaluating prevention programs. From that list of 46, so that was whittled down to about 20, and the Robert Wood Johnson Foundation then went and did side visits with each of these programs and came up with a list of 8. And what they were really looking to do is, besides evaluating something that, so they called their program Strengthening What Works. And there is very little research in many of these communities, in refugee and immigrant communities. When we have to do a grant application, we still have to look for data that talks about mainstream populations, and then kind of use our field experience to make the connections to our own communities. So there's really hardly any research still. But they were hoping that by doing these evaluations, they would come up with something that could actually come across as a best practice in these individual immigrant and refugee communities. So moving from evidence-based practice to the realm of practice-based evidence. And while they did that, they were hoping that they would raise the evaluation capacity in the staff in each of these organizations, because it was a 3-year project, and they were crafting it in terms of a collaborative agreement more than a grant. So the programs that they selected was the Youth Empowerment Project, which is an in-house youth program that we run for Asian American teens between the ages of 14 and 19, all high school youth. We try not to call them kids. So the program is predicated on the notion that if we provide these Asian American teens with the knowledge, skills, and try to raise their critical consciousness around intimate partner violence and the many different kinds of oppression that actually are interconnected to maintain and continue into the cycle of abuse, that would empower them to act as agents of positive social change. And that's also a learning that came later in the program, because initially when we started the evaluation, we were trying to think that we are creating the leaders of tomorrow. But that's an interesting story I'll tell you later. And the other program that they wanted us to evaluate was the Teen Dating Violence Program, which is a program where we go into schools and do a teen dating violence curriculum. And we have 3 versions of that same curriculum, one for all youth, one that's very geared towards Asian American youth, and another was focused on training trainers or training mentors, because we heard, as we did our teen dating violence curriculum in schools, what we heard was it raised the youth's awareness. So they started identifying things in their lives, in their peers' lives, and they understood that what was happening was abuse. But they did not have that support in their school communities, in their families, definitely not. So they needed people, guidance counselors, teachers, coaches who had that knowledge, who knew how to support a person who's going through an abusive relationship, or who has a friend in an abusive relationship. Who do they go to for help? So some of the benefits that we really found when we initially approached the Robert Wood Johnson study was it was giving us the opportunity to build that evaluation capacity in-house. And it's something that we had really long hoped for, but never had the funding to do. And it was providing in the form of something that they called a program capacity consultant, or a PCC, technical assistance from the local community, which is the role that Tien stepped in. And we had technical assistance from a national organization, but that was more through emails and periodic visits. But with Tien in-house, it was almost like, say we are coding a journal and we run into something that requires immediate help, that we require immediate assistance with, and we just knew we could call Tien and she would be able to guide us through that, because none of us had that evaluation expertise or the knowledge. Even when we were working initially on the logic model, we didn't even know how to differentiate between outcomes and outputs, and even objectives and outcomes. So she really helped break down that jargon and make it accessible to us. And it was a new perspective, because initially when they started the study, it was based on community-based participatory research norms. So before that, when we had partnered with academic institutions, it was more like because we had the standing in the Asian American community. We were a grassroots organization. We had the Asian American subjects that they were looking for. So we were a good partner to work with. But somehow we never got a lot out of those efforts, because all we have is something that tells us that we partnered with such and such organization to do this study, but somehow we didn't really reap the benefits of those studies. But this particular study was premised on CBPR norms, and we had high hopes from it. And program reflections, when you're working very closely with a program and with the participants, you're so close, sometimes you miss the small things that end up making a huge impact in the program, something small in the program delivery process. Maybe even it's something that I said to a program participant during a one-on-one meeting, but when we stepped back, when we started evaluating the program and started thinking what was really the change that we were looking for, what were we looking to do, then we realized how small things actually play a big role. And it gave us that opportunity to reflect on the program, the content, the delivery, even the approach of the facilitators, and what each facilitators got out of each session. That was so starkly different. When I was co-facilitating one particular session with another ATASK staff, and we put together our facilitation notes individually at the end of the program and then compared it, we realized that maybe from the response of a particular participant, the two of us came up with completely different, we came away with a different understanding. So we had never done those. We had never engaged in those processes earlier. And I really appreciated that. And this also gave us the opportunity to come across some amazing organizations across this country who were doing some astounding work. We had never heard of them. We had never heard of the work they were doing, but it brought together this pool of 8 grantees, and we found there were similarities in our communities, there were similarities in our community norms, there were similarities in our client populations, but of course, each of us was struggling with funding. That was another similarity that we had. But we were all trying to be creative in our own ways to do the work in our populations. And that was rich information for us. And, yeah. So some of the challenges that we had, it started off as a pretty challenging process, just because even though the foundation started the study based on CBPR norms, the national consultants that were chosen, they came to it, as Tien was saying, with a little p. And it was more of the same experiences that we were having. Again, they were coming to us and telling us what to do and what we should find relevant to our programs, what we should think is important to evaluate. There again, Tien really helped us with those difficult conversations because we were pushing back and we wanted to do an evaluation that was true to our program priorities. And we didn't want our youth, we really pride ourselves on being on the program being youth-led, and we are really serious when we say that we want it to be youth-led. Every small decision, we run it by the youth program participants. So there was a lot of pushback initially, and when we came together to decide what we should evaluate, and we realized that we were looking to create leaders, but when we spoke to the youth, none of them really saw themselves as leaders. Even the alumni that we had, none of them were really considering themselves as leaders, and that had us worried because they were doing their actions were actually showing us that the program had impact, but none of them were really seeing themselves as leaders. So we had a brainstorming session with them, and we realized that these are Asian American teens. They've been brought up all 14 to 19 years of their lives with the notion that you have to be humble, that you don't toot your own horn, and so you don't see yourself as a leader. The president is a leader. I'm trying to make change happen. So we revised the entire concept to creating agents of positive social change. And that's also something that they came up with, so we were extremely proud of that. And when we started deciding what evaluation methods to use, that was another learning moment because once again, the researchers we were working with, barring Tien, were really looking at it in a linear fashion. So they wanted to see, okay, so we can do a survey, a pre-survey and a post-survey, but that tells us how their knowledge changed. You're saying that you are raising their critical consciousness. How do you get that? You're saying that you're creating agents of change. How do you measure agency? These are all difficult concepts to measure. So what we kept telling them is some of these youth come from very, very vulnerable families, and they're not good test takers. Some of them are first-generation immigrants. They are ESOL speakers. You cannot expect them to do very well on tests, that tests them on very difficult, hard, challenging concepts like these. So we tried to talk to them about the journals that we had the youth keep, and we were always very impressed with the information, with the data, with the qualitative information we got from those journals, because they reflected. It gave them an opportunity to reflect what they were learning in the program. It allowed them to make the connections between their learnings and their lives and their communities, what they were seeing. So, and also how they wanted things to change, and how they saw their role in making that change happen. So finally, after a lot of discussion, we came across a way where we could code the journals, two staff individually coding them, and then coming together for reliability, and then analyzing them and getting that rich qualitative data actually translated. And we also had a skills rubric that we came up with, where each youth self-evaluated their skills at different points of the program. And besides that, we had facilitators reflecting on their own experience during the program, so that and to measure agency, that was the most difficult, because we had them come up with a group awareness campaign. At the end of their program, they had to come up with an awareness campaign centered around intimate partner violence to raise the awareness of their communities. And individually too, they had to do something that could be as simple as writing a poem that they could do at an open mic session, to something as critical as testifying at a city council hearing, which many of them are doing now on this issue. So those were the measures that we came up with regarding agency. And despite the initial challenges, what we finally came up with when we put the case study together and we had those data and we translated the reams and reams of journals that they wrote, and tried to make sense of the individual projects. One of them is a huge chandelier of paper cranes, with each of them having an anti-violence message on it. So something like that, how to translate that. And some of them who did not want to write in their journals, but they drew pictures, and through those pictures they tried to express what they were feeling. And so making that into a coherent piece. And when we had that product in our hand, and how we have been using that data to something that's very important to us, to leverage funding, and we have based that data, and we've got federal funding for programs related to the Youth Empowerment Project, and it's all because of that whole process. And at the end of it, now even somebody like me actually can understand and think beyond just a plain survey, and that there are other methods to do it, and what we are doing, or how we can translate our own experience, our own understanding of a program, of the impact of a program, into evaluation methods. I think that was something we really appreciated. And we have disseminated not the case study, but the findings among our youth, because they were so integral to the process. And we piloted the surveys with them. We changed the wordings based on their feedback. We made sure that what we were evaluating was relevant to them, and it actually made sense. We were not asking them questions that we had not even talked about during the program. So, yeah. I think it was a very, very empowering process at the end, and I'm so glad we had Tien's help with it. Yeah, I think that was all right.
Good. Thank you again. Dr. Tien, she's a great partner to work with. She's wonderful to work with. So I'm from Haiti. I'm a trained physician from the DR, and I work in Haiti for a few years. But when I come here, I always have some interest in research. But as a community-based organization, we don't have that capacity to pull this together. So finally, we were funded by Harvard through the Catalyst Project to do a small program, and I was able to invite Dr. Tien to work with me in that little program, because working in the Asian community, I've seen people with stomachache and headache, backache, and they go to their primary care doctor, they cannot find anything. And many of our trained Haitian physicians, sometimes they don't screen the patient for mental health. They just give them the pill over and over, and then they're still having stomachache, backache. I've seen women suffer from postpartum depression, and then they said that they will go to see herbal doctors to have some teas, some leaves over the head, because they believe the breast milk go to the head. And they will not go to see a mental health professional for treatment. And later on, Dr. Tien and I were able to come with a small project to looking at mental health literacy in the Haitian population, because we figure out that there's a lot of Haitian suffering from mental health disorder, but because of the stigma and lack of education, so nothing's been done about it. And right after the earthquake in Haiti, so people were able more to be open to talk about mental health. And I've been traveling every year to Haiti, helping, and I can tell you that mental health in Haiti, it's really in the back burner. There is no money in the government budget put aside to address mental health illness in Haiti. So, but here in Boston, again, even though we have some Haitian professionals, we have some organization, but there is not a lot of effort geared toward addressing mental health in the Haitian community. After the earthquake, we get a little bit of money from the state to address mental health, but after 6 months, it was over. So people get stuck. So this project, I'm going to give you just a little bit background on Haiti so that you could have a sense of the Haitian population who they are. This is a map. As you can see, Haiti is right here. So Haiti is an island. We share this island with the Dominican Republic. Two different countries, two different cultures, even though we have some similarities, but two different countries. They speak Spanish, we speak French and Haitian Creole. Haiti, we share the island with the DR, and Haiti is the third largest island in the Caribbean, behind Cuba and the Dominican Republic. The population right now is close to 10 million Haitian. We speak Haitian Creole and French. When I was growing up, Creole, that's the language you speak at home. And French, that's the one we were taught in school, all the books. But since 1991, Jean-Bertrand Aristide changed those things now. So Creole become, and the French, both official language in Haiti. So in terms of religion, Catholic, Protestant, and Voodooism. In the past, Voodoo was not recognized as a religion. Again, Aristide again bring back Voodoo as an official religion in Haiti. Because Voodoo were more tend to be uneducated, the poor people in the countryside who practice those practices. So Haiti means land of high mountain It was the most productive French colony. In 1971, a slave revolt had culminated in the elimination of slavery in the island. In 1804, Haiti became the first independent nation in Latin America, the first post-colonial independent black-led nation in the world, and the only nation was independent was Ghana as part of a successful slave rebellion. What some of the consequences because of the fact that Haiti became the first black republic in the Western Hemisphere? So Haiti was punished by world powers for fear of exporting that revolution. Haiti independence was not recognized by most world power. Even for French, you have to pay millions of dollars to be recognized by the French. So, as an independent nation, and since then, Haiti has never been able to stand on its feet. Boston Haitian community continued to be one of the city's fastest growing ethnic community. Boston is home for 45,000 Haitian, with an estimated of 80,000 statewide. And we do not take into account some undocumented Haitian. Massachusetts has the third largest Haitian community after New York and Miami. And now Miami and New York, they're competing very close in terms of which one is first. So it's easy to think about Haitian immigrant as an homogeneous group. In fact, Haitians are more complex and diverse. There are subcultures within the Haitian culture based on class, skin color, education, family, and economic status. So class determines like access to education, access to certain position and privilege, what language you speak. If you speak French, that means you're educated. If you speak Haitian Creole, that means you're not educated. And how comfortably you are communicating, and how powerful you feel over your life. So historically, light complexion is associated with privilege and money. So it is surprising to see a light-skinned person who is poor in Haiti, what we call mulattoes. Mulatto. So class affect our beliefs about health, for example, how superstitious you are. Voodoo is part of the Haitian culture in the same way that Christianity is part of American culture. Everyone is touched by the beliefs, whether you accept them or not. Poor and uneducated are more likely to embrace it and practice it openly. I'm talking about voodoo, for example. Educated, middle class, like publicly denounce it, but privately practice all Haitian believe in voodoo, but not all Haitian are voodoo practitioners. But we all do believe that voodoo exists in Haiti, but that doesn't mean that all Haitian practice voodoo. And there are some relevant cultural facts when Haitians come here. In Haiti, we tend to be more collective, and here we are more individualists. And the sense of relationship lost here. And in Haiti, like it's a village that's raise a kid. So we share the food together, we care for one another. But when they come here, that being lost. Moun passe droit. That's if you are mine, so I cover for you, I protect you, I care for you. We are connected. The sense of community is very important for them. And we have what we call the laku concept. You can have a large piece of land and have different houses in the same piece of land, and everybody cook together, we share everything together. And reputation is very important. We might be poor, but we care about what people are saying about us. So we protect ourselves. So protecting the name and keeping honor in the family are important. So all for one and one for all. And we are deeply religious. The Haitian health belief system is one that consists of several networks of traditional, mystical, and holistic approach to healthcare. So effective treatment requires a provider who can navigate between the two worlds of the Haitian belief system, including religion and modern medicine. Because in the healthcare alternative for Haitian, so you have two systems. You have the traditional system and you have the modern system. Under the traditional, if I'm sick, based on my belief, how I see life, I could either go to see a voodoo priest or a pastor or go to see a doctor. So people navigate between the two. If I'm sick, I go to a doctor, and for months, nothing happened. So I might say, something is wrong with me. I better put my feet in water and find out what's going on with me. So I could go and see a voodoo priest, and then he could say, okay, your disease is not of natural cause, it's more likely supernatural. So we have to do some ritual. We have to get a chicken, cut the neck of the chicken, do some ceremony, a lot of things. So, and people feel better. So there's not a lot of research as done on Haitian in Haiti or in the U.S. Research finding for Haitian in the U.S. does not necessarily apply to Haitian in Haiti. So mental illness is highly stigmatized in traditional Haitian culture. Few readily admit or recognize being depressed. Mental illness may be thought to be as caused by supernatural forces like curses, possession, malevolent spirit, or vex loi, the spirit. There is tremendous shame attached to mental illness in Haitian culture. So being from a country in which mortality due to infectious and nutritional disease is common, psychiatric disorder, unless they give way to gross social disturbance, are minor practical importance in Haiti. Last time we checked, there were only 26 psychiatrists for the entire Haiti.
How many?
26. And most of them live in Port-au-Prince, the city. I went to the second largest city in Haiti. There is not only a psychiatrist for almost 300,000 plus people living there. They only have one psychologist for the entire second city in Haiti. So Haitian immigrants are not good consumer of mental health service because they lack of information about mental health and mental illness. They are not aware of when they need help and where to get it. So many Haitians rarely consult mental health professionals for psychological and emotional disturbances. Many Haitians, particularly the less acculturated and educated, tend to attribute symptoms of mental illness to physical disease or other external forces like God, spirit, curses, or loss of family, job, etc. So as I said before, there are only 26 for now in Haiti. Only 7 work in the public sector. Cape Haiti, they don't have any psychiatrists. Only 1% of the government budget go to education and does not include mental health. Access and exposure to traditional mental health services in Haiti is virtually non-existent. So only crazy people go to see psychiatrists. Some of the things that people in Haiti said, or psychologists. Only a handful of nurses are trained in mental health because doctors and nurses are less inclined to psychiatry or mental health expertise. Most people, after they go to med school, they tend to go to OBGYN, pediatric, but psychiatrists, no, if you go there because you yourself have something. So that's why we don't have a lot of psychiatrists in Haiti. People tend to be more OBGYN or primary care physician, internist, so on and so forth. So unless the behavior pattern put the public at risk, it will not be addressed. Some Haitians may be hesitant to take psychoactive medicine for fear of dependence and mental illness. Because there is no separation between body and mind, Haitians do not have a well-developed vocabulary to express emotional distress. They tend to express emotional distress physically. So they might have some mental illness, but they tend to express it in terms of pain, something physical. A lot of mental health problems are being seen by primary care physician. Physical pain that cannot be explained. So a group of Haitian and a non-Haitian professional with a daunting task of building mental health capacity to address Haitian mental health needs here and in Haiti. So that's the mental health that created right after the earthquake, and we've been traveling back and forth to Haiti trying to help the Haitian population over there in terms of mental health. Haitian Mental Health Network, we work in Boston and Haiti, we work in Miami and in New York as well. And last time we did a trip to Haiti, and I was surprised to discover still in Haiti they don't have a master program in psychology. So they only have a bachelor program. If you want to have a master in psychology, you have to travel to France or Belgium or come to the US or somewhere else. So that's something the Haitian Mental Health Network in Boston is trying to help them over the 90s. Some of the pictures you see from the student from the Faculty of Science of Psychology in Haiti, but they don't have a master program, as you can see here. So we go over there, we did some training for them. So in conclusion, this framework gives you a general understanding about the Haitian mental health. This framework does not account for subtle variation and practices due to subculture based on class, education, skin color, and geographic location. Thank you.
So I want to just extend a little bit of what Dr. Joel was saying. Just given this complex background of the Haitian community, part of what he asked me to do in working with him is to develop a survey that would capture mental health literacy in a culturally authentic way. So he and I actually met at a community colloquium where he was presenting qualitative findings that were supported by funds from the Tufts Clinical Translational Science Center. And in this study, he had hosted 3 or 4 different focus groups out in the community to ask Haitian diaspora, the Haitian community living in Boston, how do you describe mental health or emotional problems? Because the idea that Haitians didn't know about mental health, we felt like was false, because they present with mental health issues and seek treatment for mental health issues in a physical or medical setting. And so as he was presenting this research, we were introduced to one another and sat down and collaborated, began to look at the findings from his qualitative studies, extrapolated from those findings key critical indicators of mental health symptoms that we then developed together into a mental health literacy survey, which we then translated back into Haitian Creole, and Dr. Joel took on the daunting task of collecting data in the Haitian diaspora, drawing from research funds here from the larger college, and was able to administer 135 surveys, which we're in the process of analyzing now. So I just wanted to show you a couple of the items on our inventory. So part of what we did was we first created 5 different indicators of mental health literacy. First, recognition. So we had a list of mental health conditions that were Western-based that included mood disorders, neurological disorders, as well as major mental illnesses, and asked people to basically check off whether or not they recognized these conditions, and they got a point if they did recognize it, no points if they didn't. And then we developed these statements and asked folks to articulate whether or not they know of anyone who's ever said something like this. Because of the issue of stigma, our entire survey is framed in a way where we're asking participants to talk about somebody else they know rather than themselves. And so we had a series of questions that asked if they recognized these statements or these symptoms, and then they had to check off whether or not they recognized these symptoms as a mental health problem, a formal mental health problem, or as a personal problem. So that's how we tried to distinguish between how they characterized it. And you can see here that these are symptoms of psychoses that are mixed in with sort of Western DSM-R symptoms as well. So the idea of, a person saying they hear voices, someone talking to themselves, mixed in with items that we extrapolated directly from the qualitative surveys. For example, a person with a nerve crisis or someone who's catatonic, like sitting with their lips pursed and tight. We then also asked, as part of our literacy indicators, what people attributed to mental health, so that we could get a sense of how sophisticated their understanding was. And these are just some of the indicators in that area of our survey. Again, we tried to compare and include indicators that were what we would see as standard Western attributions to mental health or co-correlates of mental health, like substance abuse or family predisposition to mental health conditions, as well as cultural beliefs that are attributed to mental health, like the act of breastfeeding as a catalyst for depression among women. And our response survey was no, maybe, yes, and I don't know. The final piece of literacy involved a series of questions around people's knowledge and awareness of services that were available for them. And again, here, we included both sort of Western typical services like programs and people, as well as more open-ended choices that were more culturally relevant, like local priest or voodoo priest, or a family member or someone who was close to you. What we plan on doing is running some crosstabs with the Index of Mental Health Literacy that we extrapolate from these surveys against questions that we had that tried to capture participant help seeking, or what we described as mental health agency, as well as, and I didn't include these indicators up here, but as well as indicators of stigma, so that we could explore the relationship between literacy, help seeking, and the role of stigma. So these are just some of the items on our survey that we created to explore a person's sense of agency or help seeking. And again, we made sure to include indicators of Western acts of help seeking, as well as traditional, more culturally informed acts of help seeking as well. It's a study that we're quite excited about in terms of providing us with good solid baseline data, at least for the diaspora here. And I think we're hoping that we'll begin to explore and learn a lot more about what the implications are in terms of program design relative to prevention, as well as intervention. Just a quick preliminary piece, we looked just very briefly at all of our questions, and there was one in there that asked participants to identify whether or not they felt like receiving education about mental health would improve their life and their happiness, their sense of happiness. And 90% of the participants said yes, which we found very, very surprising. And a follow-up question to that was, would they be willing to attend a free session on education about mental health? And again, a very high 90% of the participants replied that they would. So as we were sitting down and trying to understand that, Dr. Joel was explaining to me that education, or the opportunity for education, is something that's highly valued. So while it may not directly respond to their eagerness to learn about mental health, it's their eagerness to respond to educational activities. But knowing that, I think, really begins to sort of get my brain thinking quite a bit in terms of how we would design prevention and intervention from an education stance rather than from a curing stance, which may promote stigma, as opposed to framing prevention and intervention from a wellness and educational campaign, which would dilute the stigma. And just in closing, I wanted to highlight a couple of things that we didn't get to highlight about Deepa's project, which I thought was also very unique, apart from the wonderful examples that she offered about the ways in which they grappled with design and research and trying to make it very organic to their program and the values of their program. Some of the real concrete, I think, deliverables which they've been able to use to draw down more funding are surveys with response items that are really youth-led. I remember the first survey that we piloted with the youth, we had, the usual standard Likert scale of a little bit, somewhat. I can't even remember what the whole scale is now, but several of the youth sort of wrote back on the pilot their own responses, and it ran the gamut of "no way, man" to "hell yeah" or something like that, right? And we sat down with the team and we said, and part of this came from Deepa and her team. She said, "I really want this to be youth-centric. I want them to be able to articulate how much they feel about this, and if that's the goal, is to measure how much, right? Why can't we use their language?" And so we had this big meeting with the Robert Wood Johnson folks and advocated and pushed for a shift in the change of those response items, and we changed the end enthusiasm one a little bit to absolutely, or I can't remember, but they came up with a different term. But I thought that was really quite moving. It felt like a victory for the organization. It certainly was a victory for the youth. They talked about their participation in it quite a bit. And then the other piece was identifying research parameters for the organizations around the management and the storage of data, around ownership of the data, and around informed consents. And again, each of those designs and those decisions were made in such a way that it was really organic to the values of the organization and the small staffing relative to the organization. A lot of conversation. Do we really have to put this under lock and key? There's 2 of us in this, in this department. Why do we have to sort of put it under lock and key? And what does that mean in terms of money and funding to sustain it? And so it was just a thrill to be a part of their learning process. And I think that leaves us about 10 minutes for discussion and question, if anybody has any. And then we'll call it a wrap. I think we're going till 4 today. So we're good. Joanna, yeah.
Yeah. I think that's so interesting. So you came up with a new Likert scale that is relevant. The responses are relevant for teenagers and use their own words, but still capture the range of response from strongly disagree to strongly agree.
Yeah. It was really quite, I had never even thought about it from that perspective, because I'd always been so anchored in, my own thinking about our general Likert scale, right? So why would it matter?
But it seems like that would not only be relevant for Asian youth, but for, all youth.
Yes.
You might have developed a new response, a new Likert question with response options.
I agree. I think that's really neat in that sense, because it really allowed us to get to the content validity of that construct relative to their particular experiences, as opposed to an adult-centric sense of what that construct was going to be. So that was really exciting. They did lots of really, really neat things to sort of promote their things. I remember they had a bake sale and made cookies with anti-violence messages, and we were all sitting there, and again, thinking very stereotypically Asian. Even myself, I was so embarrassed. Well, maybe we can make fortune cookies and put, anti-violence messages in them and then sell them. And the youth and Deepa and her team came back the next week, right? Because I was out there twice a month, so they came back a couple of weeks later. And they're like, "We're not making fortune cookies." That's just so stereotypically Asian. We're making, what did you
churros.
guys? Yeah.
Mexican churros.
Mexican churros. And they stuffed the messages in there, and they went and sold them at college campuses and at high schools to raise money for their program.
Well, I can imagine there must be so much heterogeneity within the population that you serve. And, I don't know if you're Indian, but Indians used to be considered white, and now they're considered, at one point, and now they're considered Asian. So, it just shows you the social construct that race
It's
is.
interesting you raise this example, because it's one of the examples we bring up with the youth when we talk about, how race is, it's created by society.
Right.
Yeah.
Yeah.
And that was another point that came up in a lot of our meetings, because the big shift from the funders was how do we, we've put all of this backing in these 8 organizations, and we want to create tools and products that we can standardize and generalize to other Asian youth or other minority youth prevention programs for teens and dating violence. And part of our work really during that time was trying to find a way to fit that bill, building locally at the model, translating back up, but emphasizing the importance of being flexible enough in whatever the tool was to accommodate other ethnic perspectives, right? So we gave that example of, the youth, and it was a really powerful story to be able to say to the funders, for example, our collection of Asian youth made Mexican churros, so you have to be able to sort of design these activities in a way where you're promoting positive identity and letting sort of youth take the lead in that, and breaking down, because part of managing violence is breaking down stereotypes, right? And if we standardize too much, we will be perpetuating them. So, it was a really moving partnership.
It's a wonderful example of the fact that you can do participatory action research with a big P. And it doesn't have to take tons of extra time, but it does take a particular stance of being respectful and listening very, very hard. And the flexibility, and I think our students don't always get that. They sort of think, okay, you give a basis 24 at the beginning, you give the basis 24 at the end, we compare the 2 scores, we know how well the program's going. But in fact, when you listen, it is the wee small things that make a difference, and you learn so much. I really applaud you on carrying forth these 2 projects with participation with a big P, and I think you were just really enacting the principles and not just acting the principles. So that's very exciting. I'm so glad it's taped, because I was trying to convey this last night with students with video, and they're still trying to, well, is that qualitative? Well, nobody listens to qualitative. Well, it is and it isn't. It is and it isn't. And you have to be bilingual and multilingual also, but beautiful example. Thank you so much.
Deepa would be great to come and speak in your class. She has some wonderful, as well as Dr. Joel, some wonderful examples of YouTube videos that the students have uploaded as part of their sort of qualitative project. That piece around transforming, sort of measuring youth leadership to agents of social change was just huge.
And it's powerful.
Right, because it came from an evidence-based model, right? So everyone was into
all of that,
programming
and
around
blinders
youth leadership.
on.
Yeah.
And again, when you listen, it shifts the whole thing and the intervention.
Yeah.
It's just beautiful stuff.
Yeah.
Tien, I know that you have a multi-year history of work with ATAS.
Yes.
That also feels unique to me, the way in which these relationships have grown over time.
Yes.
And you really are embedded in a way that many researchers aren't.
Yes.
Could you say something, and you each commented on how wonderful it was to have this working relationship with Tien. I'm assuming there's something about time and trust that's important in this mix. And would any of you want to say anything about that?
I think, Dr. Joel and I were having lunch today, and I think a lot of it comes from the shared identity. Even though we all come from very different ethnic groups, I'm Vietnamese. I think we have a collective experience of being othered and being in immigrant communities and being committed to empowering the community as well as to empowering individual capacity in the community. And so I think there's that understanding that comes off organically when we have conversations. That was why I put that first slide up with the frog and the fish. I mean, I think it's such a natural and a very benign question. How's the water? You know, it's like a researcher coming in. And the second question with the guy shaking the guy's hand, knowing that it's his head. So again, very natural social and appropriate social nuances, but in some ways, you know, there's a familiarity that happens immediately where you don't engage in some of those missteps, and I think it does create that trust. But I think you're right. There's that deeper commitment. You know, at ATASK, for example, we've developed a whole program model there for them to use. Created a strategic plan to help them rethink about their staffing so that they can be more fund ready, and so that I created a whole assessment and interview protocol guide that was evaluation ready, which has been really powerful. And through that work, we've really mentored a lot of the staff there. 3 of their staff have gone on to apply for MSW programs. 2 of them have sort of moved on into pretty good policy analyst positions. Deepa is going back for a second interview as the Associate Director of Community Relations at UMass Boston next week. So it's really quite powerful. And Dr. Joel, you know, secured some funding through the Harvard Catalyst as a spin-off of this project that we're doing, which we just completed last summer as well, that involved a qualitative analysis of medical community health centers within a 10-mile radius of CACR, because we wanted to get a sense of how they were seeing the needs of the Haitian community, because it felt like a nice dovetail between what we're going to discover here and how they're approaching their work there. And so the combination of both of those pieces will hopefully launch and help to launch the Haitian Mental Health Network in a meaningful way. But I feel like it's really sort of a blessing. It's very transformative for me as well, you know, to be able to take these skills and translate them back into really meaningful projects that have real time impact, you know. So thank you for asking that question, Stefan. Yeah. I think it's very good. Thank you, everybody.
Thank you so much.